Right. So I'm going to be talking about diabetic retinopathy screening, how it started off in the UK, and then what work I have done in Zambia in Africa. So in the UK, if you look at the populations, we've got 4 nations, and this diabetic screening program is separate in these different areas. Each of these nations have got their separate program. So Scotland has a population of 5.2 million, Northern Ireland 1.8 million, Wales has a population of 3 million, and England has a population of over 51 million. And in England, if you look at it, the diabetes is 2.6 million diabetics. So the diabetic eye screening program is actually linked to the NHS in England. So it's the NHS diabetic eye screening program, and this depends on early detection, identification, and appropriate treatment of patients with sight-threatening retinopathy. The 4 UK nations were one of the first countries in the world actually to introduce systematic national screening programs for diabetic retinopathy. The National Service Framework for Diabetes was set up in 2003, and by 2008, we actually had local retinal screening programs covering the whole country. The local programs in England deliver screening in line with the screening program, national service objectives, and they also have quality assurance standards in place. Now, there are various models of screening that are used in the UK, and this vary from screening in static units using cameras in the hospital or in the diabetes center, mobile clinics where they are either in the general practitioner surgeries or in screening vans, or there are some optometry-based practices as well by accredited optometrists. All 4 UK nations use screening and accreditation package for screeners, which is offered in conjunction with City and Guilds, and they award them a level 3 qualification in diabetic retinopathy screening that consists of 9 learning units. As far as quality assurance is concerned, all programs carry out their own internal quality assurance checks by regularly monitoring their screening data, and the programs are also held accountable through external quality assurance processes where you have visits to the different screening programs and submissions of some key performance indicators and annual reports. So for example, we have targets to meet, like if you have identified a patient with proliferative diabetic retinopathy at screening, then you need to get that patient into the eye clinics for laser treatment within 2 weeks. So those are some of the standards that we have to meet, and that's over 95% is the expected standard. So based on the screening program in the UK, we decided to do something in Africa. The Vision 2020 Links program is a program that is run by the London School of Hygiene and Tropical Medicine, where they identify a UK trust or a UK hospital and link them to a hospital in the African country. So we at Frimley were linked with Kitwe Central Hospital, which is in the Copperbelt province in Zambia. So Zambia, as you can see, is a landlocked country. That's there, and it's got 10 provinces. And the Copperbelt province was one of the provinces where we were linked to in Kitwe. If you look at the eye care in Zambia, the facilities are pretty poor. So you have 3 tertiary hospitals, which is the University Hospital in Lusaka, Kitwe Central Hospital, and Livingston Eye Hospital. At secondary level, they have 4 provincial hospitals, and then they have primary care hospitals. We decided to roll out the screening program in the Copperbelt province, and the major towns that we targeted were Ndola, Kitwe, Chingola, Mufulira, and Luinshire. And the aim of the program was to reduce visual mobility caused by diabetic retinopathy by facilitating an early diagnosis and treatment of sight-threatening retinopathy through population screening. The objective was that you would offer annual retinal screening to all the eligible individuals who have diabetes, and the screening would be carried out with a digital photograph, and those identified with potentially sight-threatening disease would have rapid access to treatment, assessment and treatment. Like I said, we decided to focus first just on the Copperbelt province. funding has been, as you can imagine, is a big issue in Africa. So what we did was we actually linked in with the private mining hospital in Chingola, which offered to run the screening program for a year before it was then taken up by the Ministry of Health. The other thing was the people were not in Africa were not aware of how diabetes can actually affect the eye and cause blindness. So we had to do a lot of education programs for raising the public and awareness, as well as awareness amongst the physicians that this needs to be done. Then, of course, we had to train the personnel to do the screening and identify the patients. The other problem we faced was that we did not have a single list of all diabetics in the catchment area. So we had to actually go to the pharmacy registers sometimes to actually collate that register of diabetics. We also had to run education programs, and I think running education programs in churches, etc., were actually much more beneficial than trying to write letters. Capacity building, if I tell you that, the number of ophthalmologists in Zambia, they have 10 provinces, they only have 8 ophthalmologists there. The rest are all in training, and so we decided to use unskilled workers to actually do the screening. So these are high school dropouts, and we train them how to take pictures with the camera and also to grade the images. So what happened at screening was, so you can see there's a little banner. That banner was they used to publicize screening, and they were told that this was the time this mobile van is going to be coming here for screening. The patients are then come in, they have a registration process where their blood sugar is tested, their blood pressure is tested, and besides taking the history, then they have their vision tested, dilation drops applied, and intraocular pressure tested. Pictures are taken, and then the pictures are then sent to the laptop, graded at the same time, and then the patient is counseled. This needs to happen at the same time, because in Africa, if the patient comes in and you haven't actually told them the results of the screening program, then you may not get them for treatment. So you need to actually counsel them and tell them this is what is there. You need to actually have treatment delivered this way. And if the changes for sight-threatening retinopathy were found, then they were referred to the Kitwe Central Hospital. Otherwise, they were actually invited for screening in a year's time. The patients who were brought into Kitwe Central Hospital then actually had further tests done. So at the Kitwe Central Hospital, they have facilities to have OCT and fluorescein angiography as well. And once that was done, then they were treated appropriately either with laser or with intravitreal Avastin injections, which was available in Zambia, and or if they needed surgery. As you can see, in the first year, we screened 2,689 patients, and the 594 were referred for various forms of treatment. And interestingly, I mean, this was just in the first cohort of patients that we had screened. Now, if you look at the International Diabetes Federation, it estimates that in sub-Saharan Africa, by 2030, you would have 24 million diabetics. And so it was really important to actually get the Ministry of Health on board. So one of the things they had found was as they did the non-communicable disease strategy, the diabetes was highlighted as one of the poorest for diagnostic facilities and access to treatment. So what we did was we actually made sure that when the non-communicable diseases national strategy came out, diabetic retinopathy screening was a part of that. So building on the success of this program, we have now actually expanded it to Zambia, the whole of Zambia, and we run a 3-day educational event at the University Teaching Hospital. We have developed a DRNet toolkit as well as a laser toolkit to help with this. And it's interesting, we do run a practical session on day 2 and 3, which is actually giving them an idea about how to set up a database, how to actually screen, how to grade the images, and how to counsel the patients. What has gone well is that all those people that we trained in Kitwe in the Copper Belt and the Copper Belt are now actually being the trainers. They are now the trainers for the groups of people that are coming in to be trained, and that's been really good. And the practical application of theory into patient assessment and treatment in a clinical setting was really valued by the people who attended it. The fact that the Ministry of Health has been on board is great. And it's the enthusiasm of the attendees and the people who actually we are training has been really good, because you're actually taking people who don't have a clue about what the eye is, and you're teaching them how to take pictures and how to grade the images. Thank you.
Thank you, Geeta, for coming, and I'm sorry I'm a little late. I was from the other hall. So thanks for Farooq and Dr. Shobha. And I think the idea is to have work along with all of them in India, and I'm glad that they're all here. Thank you, Geeta, for the opportunity to work with us. Next, who's the speaker? Yeah, so next we have Dr. Shobha Shivaprasad, and she's come to India several times. She's from the Moorfields Eye Hospital, and she's got the prestigious Ornate India project going on, and I think the hard work done by her, Arvind Eye Hospital and Shankar Nethralaya, and about 20 centers. And she also has been declared the best researcher of the year last year in Moorfields.
So today my talk is on management of diabetic retinopathy or diabetic retina. These are my financial disclosures. So when we talk of diabetic retinopathy, we're starting from diabetic retinopathy, non-proliferative diabetic retinopathy changes to proliferative diabetic retinopathy. A fourth of patients will have PDR by 15 years of onset of diabetes. So the two sight-threatening diseases that we treat are diabetic macular edema and proliferative diabetic retinopathy. So when we talk of diabetic macular edema, we always think of the inner retinal circulation that is at fault. So you can see here the blood vessels situated as the inner blood retinal barrier. If a microaneurysm occurs in the inner retinal layer, you can see how the fluid then tracks down towards the outer retina. But if you see a cyst in the outer retina, most of the time it is from the inner blood retinal barrier, but it can also be because of the breakdown of the RPE cells. Based on this, we have to decide our treatment. And our first type of treatment that is still very frequently used is macular laser. So I'll go through the type of laser, threshold versus subthreshold, patterns of delivery, and limitations. So we all know for a non-central involving diabetic macular edema, macular laser is still the treatment of choice. So if you see a focal edema, of course, we try to do the laser around the focal, at the microaneurysm or around it to decrease the leak. On an OCT, as mentioned in the previous session, you will see an intraretinal cyst accompanied by the microaneurysm. In this case, it may be central or non-central, but if it is non-central, again, our aim is to do laser. There are publications, including one from India on Navilas laser, as well as subthreshold laser using micropulse. There are small studies, and therefore we are not very sure whether subthreshold laser is any better than threshold laser, except that in subthreshold laser you do not make much scotomas, and therefore may be more patient-friendly than a threshold laser. This is an example of a micropulse laser, but you can see that by the end of it, you definitely still see scars. For ETDRS study was the first study, and of course it shows that by 3 years, 50% of the patients will have less moderate visual loss as a result of laser. So that is several years ago. What do we see with our macular laser audits done these days? Again, the mean visual acuity change in 12 months is very minimal, but at least by 3 years, it seems to catch up with Anti Veg F Therapy. Approximately 15% will gain vision and 10% will lose vision. That is 15 letters or worse. We usually give around 2 to 3 sessions to completely cause resolution of the fluid, but sometimes we do need to give more. So what are the issues with macular laser? First of all, there is a wide variation in the laser delivery and uptake. Especially with micropulse laser, we tend to give a lot more burns to produce the same effect. Laser therapy can cause loss of vision in eyes with very good starting visual acuity, and therefore most of us tend to observe those eyes to await them getting worse to treat with Anti Veg F agents. It is extremely difficult to do laser in parafoveal lesions when the visual acuity is very good because it results in scotoma. Central edema, if there is a choice, our choice is Anti Veg F agent, and if it is not available, of course, we'll have to choose laser. Macula ischemia is another area where laser is contraindicated. So when do we do laser today? In a setting where there is a lot of anti-VEGF funding available, we will reserve macular laser to non-central involving macular edema or center involving macular edema where the thickness is less than 400 microns, and that's our restriction in the UK, made by the government to restrict its use. Pregnancy, of course, we try to avoid anti-VEGF agents in these situations. And of course, a recent cardiovascular event, we tend to wait for 4 months before we reinitiate anti-VEGF in these patients. And of course, we have to give informed choice to the patient that both laser and anti-VEGF are available, especially in a country where patient has to purchase or buy the anti-VEGF agent. Macular laser may be still the standard of care. Now coming to anti-VEGF therapy, it is now the gold standard for center involving diabetic macular edema. Instead of the figures you saw previously with macular laser, here 50% of the patients will improve 10 letters, 30% improve 15 letters, and it's a very good result with anti-VEGF. But we do need a lot of injections. You can see from year 1, patients are seen every month, have their visual acuity done, clinical exam done, OCT as well. Fluorescence is done at baseline, and we also try to do an HbA1c at baseline. But you can see that we give an average of 9 injections in the first year. Only if this is possible should we initiate patients on ranibizumab therapy, because most often we waste the money and the fluid comes back and we still have to laser. So we have to be very cautious when talking to the patients. In the year 2, of course, we still see them quite often, but 8 weekly this time, and we see that we do a visual acuity and OCT at every visit and inject if necessary. What are the issues with anti-VEGF agent? Of course, you need lots of injections the first year, and then it reduces in the second and third year. We must be willing to see these patients every month at least for the first 6 months. And maximum therapeutic effect is achieved only when we see these patients every month. Patient compliance is, of course, very important, and the service provision to deliver these injections should also be appropriate. The issues with us in clinic is that the visual acuity does not correlate to the OCT, and many a times you will see these type of graphs when you look at the OCT. Some visual acuities are very, very well improved, but the thickness will still be there. So we have found, the DRCR group have come up with 4 phenotypes of response as a result of anti-VEGF agent. Most 50% of our patients will be early and consistent response when given every month for 6 months, but early but inconsistent response in 14%, and you will see non-responders are present in 1 in 5 patients. So we have to be very careful. Even in patients where regular injection was given, 1 in 5 do not respond. So when do we stop treatment? Of course, when it is macula is dry, and after 3 injections we stop. After 6 injections, if it is still wet but the visual acuity is improved, we tend to stop. I got the third one wrong, but I'll leave that. No response in anatomy at 12 months, and then you develop a microvascular event while on treatment, then we have to stop. What is a broad stopping rule? If the visual acuity is lost by 10 letters or the macular thickness is still above 400 microns at 6 months, then we stop, because we feel that there is no point giving more lasers. But if the visual acuity is very good or the macula is dry at 6 months, then we call it a success criteria and stop treatment. So sometimes we are unable to decide whether or not to continue, and people tend to look at outer retinal integrity to restart a patient on treatment. However, in many patients, we do not see this outer retina because of the fluid, and therefore that is not a reason why we should, that should be considered when we restart therapy. It must be other factors. Other causes of poor prognosis are, of course, epiretinal membrane and vitreomacular traction. These are very difficult conditions to treat. We must always remember if the macular edema is occurring in one eye, that diabetic retinopathy is a bilateral disease and peripheral retina has to be monitored. Color photos have to be taken regularly and at least 6 monthly checkup of the other eye. And you must remember that PRP may be required although the patient is on Anti Veg F therapy. We do give steroids for them, but we only give steroid as a second-line agent, sometimes intravitreal triamcinolone, Ozurdex, or fluocinolone. So in Ozurdex, of course, we give it in only pseudophakic eyes where there is persistent macular edema after anti-Veg F therapy. Iluin is long-acting. I think it's not available in India. This is given sometimes when patients respond to Ozurdex but need a lot of them. What do we do when you have cataract surgery, require cataract surgery with diabetic macular edema? We tend to give steroids at the time of cataract surgery, but you also can give anti-Veg F at the time of cataract surgery. There is often a question asked when there is persistent diabetic edema whether peripheral laser will be sufficient to reduce the edema. So far, the evidence is relatively poor, and we do not recommend that. But it may be needed in a patient-to-patient basis. So when we think of anti-Veg F agent for diabetic macular edema, it is still the first choice for center involving macular edema if one can afford it and the service can deliver that every month. Long-term effects on the neurons are still doubtful. There is the combination treatment may be the way forward, that is laser plus anti-Veg F or anti-Veg F followed by steroid. But treatment therapy should be individualized, and several questions still remain unanswered. We did do a trial on aflibercept for anti-Veg F for proliferative diabetic retinopathy called the CLARITY study. Here we found that aflibercept is actually superior to laser for panretinal photocoagulation. However, although very few injections were required, we must remember that the new vessels do come back once anti-Veg F therapy is stopped, and therefore we have to add panretinal photocoagulation as soon as we decide to defer aflibercept therapy. And lastly, we should not forget about systemic treatment. Our diabetic control is crucial. We remember the metabolic memory that we have seen in the DCCT and the EDIC trials that show that patients do continue to have diabetic retinopathy because of previous poor control in diabetes. Hypertension is a very important effect, and that has to be reduced, and so are lipids, according to the Accord and Field trials. So in the US, when such a study was done, you found that 20% of the patients with diabetic retinopathy had very poor control of their primary risk factors of diabetes, hypertension, and hypercholesterolemia. There are new treatments coming our way, and I think the Panorama study and the DRCR Protocol W that now shows that anti-Veg F can even be given in severe non-proliferative diabetic retinopathy. Again, it's fully challenged because there is no way one could afford giving this treatment forever, and we do need new treatment options for these conditions. Thank you.
Thank you, Shobha. Can you have the lights for a minute? Because I wanted to request that I have to go for another ICO session with Claire Devi. So you can come here so that we can have a photograph and then I leave. In the meantime, next I have Farooq to come here. And the reason I have this session is that already all, you can come here. Samir, can take a picture with Samir. Sir? Yes, yes. You can come and sit down, sir. Yeah, you can sit down. You can be seated here, so that I am leaving the thing. You can, yeah. Anyway, thank Shobha and Geeta what they are doing for India, and I wanted to get it organized through All India Ophthalmic Society. Yes, sir, sure. Yes, that's why I said Farooq, that's why he's here today. Farooq is contributing and we want him to contribute more from his BRIC and you from Ornate India, and I wanted Geeta for whatever I told her she's doing in, I know she's also, but we want to do another funding from London School of Hygiene and Tropical Medicine. She corrected me. Hygiene and tropical medicine. So with this, I think I request Farooq to do, and then Dr. Radhika should take the note so that on behalf of All India, we have to sign up with Ornate India. And I just told her we have to do that and get it passed in the county. Yeah, I think paperwork is required, and that's why I'm going to run around. But I think work will speak. That's what I want to promise you, Rajiv, Kim, and the entire people who are taking part in the program. Okay, Farooq, thanks for coming. I'm spending only a few minutes.
Thank you for having me here anyway.
Yes.
So am I going to have my slides up there next, please? Or do I need to select my own?
Proud teacher.
What happened? Is it
What about the...
Do I need to select my own?
Huh?
Do I need to select my own?
Is audio visual person there?
the audio visual not there?
Can you take his presentation? In the meantime, Dr. Farooq Ganchi is originally from Ahmedabad, but now working in Bradford. He has a Bradford Retina Imaging Center, BRIC, and I think he's already working in several parts, but we want to do something organized so that All India Ophthalmic Society can be a part of doing this, so that we have to cover 73 million diabetics, and it's going to be a...
Thank you. We talked about diabetic retinopathy quite a bit, so I'm going to change the tack a little bit and talk about retinal imaging in clinical practice, and a little bit about artificial intelligence as it is coming in over the time. So my disclosures. So talking about macular degeneration, I'm sure we all use the clinical assessment of the patient first, and helped by the OCT and often with retinal angiography both, at diagnosis of macular degeneration at the outset, as well as when we're considering further management of the patient as we go along with the treatment. So when you look at the patient in clinic, you look for the signs of wet macular degeneration in particular, you look for the hemorrhages, you look for the exudates, swelling in the retina, and if you do the OCT scan, you look for certain features such as intra or subretinal fluid. You look for what is called SREM, or subretinal hyperreflective material, pigment epithelial detachments, and whatnot. Often, and in UK, it's a standard practice to have a baseline fluorescein angiogram that would confirm the presence or absence of your choroidal neovascular membrane. We tend to use both fluorescein and ICG angiography together because it gives us more details about the choroidal circulation, in particular for the cases with IPCV. But do we really need a retinal angiogram in our clinical practice? Now, of course, when you look at the OCT, there are certain features that do tell you that the patients would have wet macular degeneration, such as the subretinal or intraretinal fluid, the SREM, pigment epithelial detachment, and whatnot, and that correlates quite often with the fluorescein angiogram, where you see the choroidal vascular network as on the picture on your left. But what is the sensitivity and specificity of the OCT and OCT on its own? So if you do an OCT, the sensitivity is quite high, usually in the 90% range, but the specificity is quite low. So it's not very specific to wet macular degeneration as such, the changes that we have just seen. In a large systemic review done for the NIHR in UK, they found the sensitivity and specificity for OCT for diagnosis is quite good, 88% and 78% sensitivity, quite good. But when it comes to monitoring the disease after you've given few injections, the sensitivity remains good, but the specificity drops down to 48%. So that's a bit like tossing the coin. You can get it right half the time. What is useful, however, is to know what exactly is seen on the OCT. So we need to know the nomenclature and the layers seen on the retina, and especially in the cases of age-related macular degeneration. We are more interested in changes seen in subretinal tissue, especially in the choroid, and deep assessment of the choroid, though it's a bit limited with the OCT, it's still possible with the newer technology. What's more interesting for us now is that as the OCT technology is improving, faster scans are possible, and when the faster and faster scans are possible, you can use the computing methods to deduct the static changes on the OCT versus changes that change with time, such as the flow. And by doing that, you can have the map of retinal tissue as well as retinal vasculature on the OCT angiography. So we in UK set out to do a study based on OCT angiography a couple of years back, and we're reporting the results at the ARVO in a couple of months' time. Based on that study and further experience, I'm going to share some of the knowledge that we have acquired. The OCTA now is quite useful. I use quite regularly in clinical practice in my cases for macular degeneration. At diagnosis, it helps to phenotype the patients and helps us to study the morphology of the disease. It also helps in the management. Though we don't have the quantitative data, qualitative data certainly helps us to improve our understanding of treatment response, but we need to learn a lot more. So we need to collect a lot more images and base our judgment on that for the final say on whether the OCT angiography would be really helpful or not. So I'm going to share a couple of cases here with you using the OCT angiography at diagnosis. The first is what we call type 1 CNV. Type 1 CNV, if you remember, is the occult CNV, as it used to be called, which is subepithelial outside the retina. And you can see here, the picture on your right shows the network seen in the deeper layer of the retina. The map below that, this one here, shows the yellow demarcation at the bottom, which is the flow identified by the computing program. That also is quite useful when you assess the OCT angiography images. Here is another example. This is type 2 CNV, which is called classic CNV in previous terminology. And you can see most of the changes are above the RPE. And you can see the fluorescent angiogram on your left, which clearly shows what is easily identifiable as a lacy network of new vessels, which leak later on in the frame. And the picture on your right at the top shows 3 layers of the retina identified by the program, and the farthermost on the right at the top shows the network of the blood vessels, which is spot on in the center of the macula, which was seen on the fluorescent angiogram. So it correlates quite well with the fluorescent angiography. When it comes to identifying the type 3 CNV, which is the retinal angiomatous proliferation, it's a bit more problematic because the flow here in the blood vessels, the new blood vessels, is vertical rather than horizontal. And hence you need to look at the map itself, which is the picture at the bottom, and look for those yellow pixels, identify the program in the vertical fashion. In some cases, however, if you're lucky, you can find that horizontal distribution of the RAP as seen in this picture here. As I mentioned about the OCT itself, the sensitivity of identifying CNV, it varies depending on which paper you look at, but it's still in about 70%, you can see it. But when you combine the OCT and OCTA together, both the sensitivity and specificity increases to about 85 to 90% in most of the studies. We looked at our own data, and we find that it is about 95% sensitivity and specificity when you use OCT and OCTA together in identifying the patients with CNV in our macula clinics. What about follow-ups? Now that becomes a bit more problematic. What we tend to see is when you treat patients with Anti Veg F injections, Lucentis, Eylea, or Avastin, you would find that the blood vessels shrink, and the classic Medusa appearance disappears, and you find that you see more of the trunks of the blood vessels rather than the branching pattern at the tips of the blood vessels. Something that is described as unraveled yarn, the picture on the right there. It's quite interesting that you can quantify the changes as well. Quite often you would see that the blood vessels area under the retina slowly improves, i.e. that is reduced with further injections. But in some cases you also find that even after regular injections, overall area of the retinal choroidal vasculature increases after the loading dose of injections. So that is why I think it is important that further studies are done on using the OCT angiography in clinical practice and in further research as well to identify its particular role in the management of age-related macular degeneration. So there are quite a few limitations of OCT angiography, especially with patients with poor cooperation. Patient needs to keep the eye still, otherwise you get lots of artifacts. There are projection artifacts that are seen at times. Furthermore, when we talked about diabetic retinopathy, it's quite useful, but it only picks up the blood flow that is fast enough that the program can identify. So some of the microaneurysms, for example, in diabetic retinopathy may not be picked up by the OCT angiography. A brief word about artificial intelligence. Now, we all, as doctors, use our own judgment using various information sources that we have available to us, starting from the history of the patient, and then using certain clinical biomarkers to come to a conclusion about patient diagnosis, and then plan the management as well. So clinical biomarkers that we've been using are based on technology assistance, whether it be the blood test, the imaging that we do, OCT angiography, or fundus photography. Professor Menon talked about the diabetic screening program where retinal images are done, and that's where the technology came in first, where neural networks were used assessing the 2D images of retinal pictures, identifying presence or absence of diabetic retinopathy. So the computers can automatically do that. That's been in practice for quite a while. Say, for example, in Scotland, the primary grading for retinopathy, presence or absence of retinopathy, has been done by computers for a while. But that's the simple assessment. Now, multiple information sources can be pulled together, and that gives even better information about the patient diagnosis. And that is what is used for machine learning. So machines, the computers are fed a wealth of data. Thousands and thousands of images are given to the computers to assess, but they need to be told what is seen on the images. Otherwise, the computers do not have brain of their own. Our group in Moorfields had presented this paper very recently, later last year, that was based on using the OCT data that collected at Moorfields, thousands of images, again, marked by the clinicians to show certain changes on the OCT angiography, or OCT scans, and then the computers were gradually learned, machine learning, that allowed them to come to an algorithm used by the Google DeepMind. And it's been said now that the computers, using this software program, can identify a lot of retinal conditions quite often better than the clinicians can do. So the artificial intelligence is something that we can look forward to using in a clinical practice, not only in retina, in glaucoma field as well. That's going to be application of artificial intelligence that would aid the doctors in their further assessment and management of the cases going forwards. So in conclusion, I think there is a developing new field both in retinal imaging. I only touched on certain aspects of retinal imaging. Autofluorescence is another area that we can talk about at the next meeting maybe. There is exciting developments happening in field of artificial intelligence, which is going to help us all in our clinical practice in future. Thank you very much.
Farooq, do you want to discuss your case? Yeah.
All right. Okay.
So we're just going to start with Farooq's case. It's a mystery case, right, Farooq?
I'll do the mystery first, then how about that? So are we going to make it interactive then? Yes. All right. So let's go to presentation. Are we there? So I'm going to share with you this patient that we saw recently in the clinic at Bradford. She's a lady in her 40s. She presented with blurred vision in her right eye, 3 months duration. The visual acuity is 624 in the right eye, not improving with pinhole. The acuity in the left eye is 6/7.5. She gave a history that she had subarachnoid hemorrhage, an intraventricular hemorrhage, and she was comatose for a while. She required metallic clip to anterior communicating artery aneurysm. When she woke up after 3 weeks being in coma, she found that the vision was blurred. So I'm going to show you her retinal pictures then. Anterior segments were fine. There was no inflammation. Intraocular pressure was good. This is what the retina looked like. As I said, the visual acuity is 624 in the right eye and 6/7.5 in the left. So first question, what are the obvious changes that you see on the retina, if you see any? It's possible, yeah, it's a good differential diagnosis, but the changes you see, do you think they fit in with Tertian syndrome? They look like rot spots. There are a couple of hemorrhages in the right retina, right? Anything else? How do I bring the pointer on the screen here? Can anybody help me? If not, I can see the pointer on the laptop, but it's not projecting here. No. So what do you think of the blood vessels? If you look at the blood vessels, not projecting very well maybe. We can see the veins quite well. Say again?
Some irregular caliber of the veins.
Thank you. Anything that you can see in the retinal reflex itself? There may be possible fluid in the macula. Yeah, it's a good assessment there. In the right macula only or both maculae? Both, right. Okay, I want to point, pointer doesn't work, but if you look at the macula, so you can see that there's some gray shadow. What about this area here? Does that look any different to you? Maybe it's not projecting well. Maybe some ischemia. Okay, so it could be ischemic. That's a good suggestion. Prof. Menon, what would you want to do next then? In assessment, when you look at the retina, would you like any other images?
Yeah, I'd like to do a fluorescence and an OCT.
Okay. Before you do fluorescence, anything else? I'll show you fluorescence as well in a minute. OCT. I'm not going to show you OCT, but I'm going to show you autofluorescence. Does that help? So that's blue autofluorescence. And it's quite useful to look at multimodal imaging in certain cases. In particular, this one, you can see there are few areas of hyper autofluorescence. Is this? That there? Maybe a little triangle coming in on temporal macula. There are few areas of loss of autofluorescence, which are big blobs. So if you remember, autofluorescence gives you good indication of the health of pigment epithelium and the retina related to that. So if you see hyper autofluorescence, that kind of indicates that the retinal pigment epithelium is under stress of some sort. And if you lose the autofluorescence, oh, thank you, that's brilliant. So if you lose the autofluorescence, that means your pigment epithelial cells are probably dying or about to die or dead. All right? And then you can have the masking, which is from the hemorrhages. So other eye autofluorescence is relatively intact. So there's your fluorescein angiogram, Professor Menon. Anything of interest? So you got a fluorescein and ICG. As I said, we tend to do fluorescein and ICG together in Bradford. So disc is a little bit hyperemic, maybe leaky disc, but there wasn't anything obvious to me, neither in choroid nor in retina. Maybe there is slight enlargement of fuzz, if that. So the OCT next. So before we look at the OCT, I want you to look at the picture on the left of the OCT, which is the infrared image of the retina. And what you find there is a dark area here in the right macula that gives you another view of the retina, looking at the color pictures, the autofluorescence, and now infrared. And infrared, if you remember, gives you indication of what is going on at your RPE layer or deeper in the choroid. So that tells you there's something not right in the deeper retina. The other eye relatively looks normal except for one area there. Right? So if you look at the OCT then, it shows that there is the outer retinal problem. In the area of the scan that goes through your dark infrared image, there is a loss of or collapse of the outer retinal layers, especially the pigment epithelium. So what do you think has happened here? Now somebody mentioned ischemia. So if there was ischemia, where is the ischemia? Thank you. So we thought this was a patient who has had choroidal ischemia, and you probably have come across patients with hypertensive retinopathy who have severe shutdown of the choroid as well. Amalric described them earlier on, where you have RPE disturbance with the triangular retinal lesions that you see clinically earlier on. And later on, you see the hyperpigmentation of the retina. And histologically, both outer nuclear layer and RPE damage comes first, and the OCT and scan here confirms some of the changes described histologically. I would suggest that if you have the access to multimodal imaging, try autofluorescence and infrared in such cases. Thank you very much.
They don't seem to have my cases. My cases are not here. No. There are cases, number 2, number 1, number 2.
यही आया मेरे पास
Can you put a disc?
जिसमें
USB?
जिसमें
You want to show your second case? I'll take it.
The second one is so the second one, I've given you diagnosis already. So it's a patient with central retinal vein occlusion. And we're going to run through some of these slides and see how we would manage this case. So that's what the patient has presented with. So it's not a true color, it's a pseudo color image of the left retina. Baseline visual acuity is 660 at month 0, as we call it. And it's got severe macular edema, as you can see on the OCT scan. The question is, what would be your plan of management? how are the cases like this managed here? So when you say anti-Veg F, tell me what would you do? Would you do a fluorescent angiogram in your assessment at baseline? Right. So define whether it's ischemic or non-ischemic. 660 is kind of a borderline, isn't it, for ischemia as well? So you won't want to exclude ischemia. If it was ischemic, would you still use anti-VEGF? Good, yeah. So my question still is, if you found that the patient has quite widespread ischemia, capillary dropout, would we still be using anti-VEGF for macular edema? Patient is phakic, let's say phakic. Yeah? Sure, sure. Excellent. So in clinical practice, you would start with your history and look out for any specific condition, underlying condition. So diabetes, hypertension, the standard we do. Coagulation factors you may want to check, but in UK, we standard is not that we check it ourselves because it's all linked up NHS system. We pass it on to the general practitioners for them to assess for any other risk factors. But good point that you made that. So we need to check for the systemic factors. Coming to the eye itself, yes, we do fluorescent angiogram, but in my practice, it does not matter whether the patient has ischemic or non-ischemic central retinal vein occlusion. If they have significant macular edema, the start of treatment would be with anti-VEGF injections, as you would do here. So let's say the patient has had the first anti-VEGF injection. Your choice, be it Avastin, Lucentis, Eylea, or whichever agent you're using, right? So we're given the first anti-VEGF injection. This is month 2. And the visual acuity has improved dramatically. This is month 3, sorry. So you've given 3 injections, month 0, month 1, and month 3, now month 2. And the vision is 6/9, the macular edema is gone. Question is, what shall we do now? He's had 3 injections so far. So month 0, month 1, and month 3. So I know the practice varies here, so it may be different. But I just wanted to have some sort of guidance as to how you treat patients here. Do you follow any particular protocol, or is it a PRN? Correct. So you treat, and depending on what happens at the next follow-up and the patient's decision, you help guide them what to do next. So this patient has had 3 injections now. Vision is 6/9. If you go by published evidence, it says that you need to give multiple injections in the loading phase to get the best results. So I would be interested to find out from your experience what the results are like when you treat the patients as necessary. But this patient, let's come back to this patient. At month 4, though he has had regular injections, month 4, vision has dropped, the macular edema has come back. What shall we do? Potential for steroid, yes. Any other option? Photocoagulation is another option, yes. But what we do is in UK, usually with retinal vein occlusion, they get 6 to 7 injections anyways. So the patient continued with injections, and I'm just skipping a few visits here now. After 6, 7 injections, it remained stable, not had any injection. Now we're coming to month 15. Macula looks good, vision is 6/12. The patient is in the observation phase, as you would here as well. Right? You want to see the next one? Oh, what's happened here? Maybe I skipped one. Anyway, what happened to the patient was after we stopped treatment, the macular edema came back again. And the vision dropped to 660. Now, that is an enigma that I face. I don't know how you manage such cases, Prof. Manin and Siva Prasad. One of the options was mentioned was using Ozurdex and PRP. But what stage, because the patient has had fantastic response to start with, macula dries up, and then a year later, the macular edema comes back.
As far as I know, there is no evidence that Ozurdex is going to decrease that any further. It may temporarily cause a decrease, but it's no different to anti-Veg F. Actually, anti-Veg F seems to be doing better. The SCORE 2 study shows that.
Can I ask you a difficult question now? Professor Siva Prasad is leading a study called LEVO, which is on retinal vein occlusion in UK. It's run for 2 years. And are you able to share any results or inside information from that
I welcome
study?
all of you to come to RO. It will be presented there.
All right, okay. So we look forward to that because that would help us guide in what happens to these patients in long term. Yeah? Anything else that you want to add, Geeta? Yep, if you switch your microphone on, because even I couldn't hear you.
No, we continue with Anti Veg F therapy because if they respond well to Anti Veg F, switching them to steroids doesn't make much difference. And
But-
they end up getting all the complications. And this is a phakic patient, you said, isn't it?
I think it was mentioned from the audience here that you want to exclude the ischemic or non-ischemic. You want to define first. Now, going back to that LEVO study, we were part of that LEVO study, and we found that one of the patients who was non-ischemic to start with became ischemic while he was still on anti-Veg F injection. Is it common to see that such change, do you think?
We had a case, not a part of the LEVO study, but just like you said, started off on Anti Veg F therapy, was still on Anti Veg F therapy, and switched from being non-ischemic to ischemic, and then needed PRP.
And then it became stable.
15% of all non-ischemic can convert to ischemic as natural history. I don't think anti-Veg F does anything to that.
That's a good point, Shobha. Can I ask you at what time frame that we should be careful and watching the patient with vein occlusion for that change to happen?
So until now, we were under the 100-day rule because of our previous studies from Sohan Singh, Hare, etc., telling us 100 days, the neovascular glaucoma time. But because we are deferring that, the Vivid and Vista study showed that it can happen at any time in the course now. So we have to do PRP for the ischemic eye if we are stopping anti-Veg F in an ischemic CRVO, because it will invariably end up with neovascular glaucoma, but at a later stage.
Sorry, I'm laboring the point here. From the clinical practice point of view, if I see a patient who is non-ischemic CRVO to start with, who's doing well, would I be able to discharge that patient after 2 years of treatment, saying that now you're not going to be non-ischemic?
If the non-perfusion is less than 10 disc areas, we are happy to discharge. 30 disc areas and above, we definitely should do PRP. And then you have got this 10 to 30 where we can't predict whether the non-perfused area will increase over time. And that's the group that we do not have an answer. But if in doubt, PRP them before we
Keep them under
discharge.
follow.
Yeah.
Thank you very much.
So I'll show you some cases. I'll just rush through them because I think we are losing time here. So the first case is a 46-year-old gentleman with type 2 diabetic, poor control. He's hypertensive, he has dyslipidemia, and he has been treated 3 times with macular laser in both eyes. His right eye is stable, left eye has macular edema. And you can see this patient here, definitely center involving macular edema, moderate to severe non-proliferative diabetic retinopathy, confirmed on infrared. Sometimes this infrared gives you a better picture than color photographs. And fluorescent angiograph, of course, showed the cystoid changes or the petaloid changes in the center as well. So the OCT now confirms center involving macular edema, very thick macula. Would everybody's treatment be first-line anti-Veg F in this patient? Yeah? Okay, so we also booked him for Anti Veg F Agent, but he went to Sri Lanka because he had an emergency trip there. And while being there, he developed an upper respiratory infection and was put on augmentin, and he had some herbal medications, no oral steroids, no immunosuppression. Then he came back 3 months later, and this is the treatment. This is how the macula looks. So the question is, did antibiotics do anything to him, or is it that herbal medicine that we very badly want to know, because it definitely cured not only his macula. If you look at his fundus, you can see a lot of his lesions disappeared. So it was intriguing, but we don't know what it is, but definitely it helped him. And then of course, he was with us afterwards, and by the end of 1 year, the fluid has come back. And if you see, the exudates are not there, but it's still severe macular edema, severe retinopathy with macular edema. So we again initiated him on Anti Veg F Therapy. So that's a definite sign of macular edema. Maybe we should have sent him back to Sri Lanka, but instead we started him on ranibizumab therapy. He's had 15 injections, vision 6/12, only partially resolved fluid. He has persistent diabetic macular edema, and then we treated him for PDR as well. So his course continued. So the question here is, what caused his spontaneous resolution of diabetic macular edema, at least for some time? We do see that in some patients, but we do not know what the reason is. But when we have spontaneous resolution, we have a few questions that we should ask, especially if the patient went into hemodialysis. They tend to have a resolution of their edema following pancreatic transplantation. Just correction of their anemia can result in a good response. But if you tell them to control their diabetes and blood pressure, it doesn't seem to have much role at this stage to make it dry like this. It may help in the long run. And then discontinuation of some of the anti-diabetic drugs can also cause a resolution of edema, and then a spontaneous resolution of VMT. So these are the common causes of spontaneous resolution. This patient did not have any of them, but still managed to improve his retinopathy, at least for a short period. So case number 2. This is a 56-year-old pseudophakic gentleman. Again, you can see his visual acuity in the left eye is 4/60, and his visual acuity was 6/6 in 2009. This is a presentation in 2018. So probably he's lost his vision in that intervening time. He presented with poor color vision of 2/17 in the left eye, central blurring. So what is the test that you would do in such instances? What are you thinking when you see such a patient? Type 2 diabetic, poor color vision, poor vision. Color vision down by 2/17? What? AION. So AION is a very important diagnosis here. PION is another important diagnosis, posterior ischemic optic neuropathy. And then optic disc papillopathy, although for them the visual acuity is usually normal. So I went down the route that this is optic nerve problem. So you can see his OCTs are fine. But he had a small VMT. VMT cannot explain a visual acuity of 4/60. Is that correct? Yeah, everyone will believe that. So we went on. This is his other eye, also fine. So we didn't have any diagnosis for him. His brain scans came back normal. He's fine. Huh? Central scotoma. Central but very small scotoma, but nothing else to say. So do we have any other tests to do now? We didn't do VEP, yeah. We didn't do autofluorescence. Pupil fine, yeah. Pupil found fine, vision down, color vision down. Visual fields, a small scotoma. Almost, you have to think twice whether that's a scotoma to worry about. We then thought it is malingering because we thought everything else is done and yet his vision is down. But this is This is what we then saw on his OCT. He has got a slight lift of the umbo or of the fovea because of his VMT. So the question is, can this cause a 4/60 vision and poor color vision just by raising that, or is this just an incidental finding? But this is the only finding this patient has. We don't know, right? Because we have never heard of a VMT causing poor color vision. So I assume the other diagnosis will be a posterior ischemic optic neuropathy where we cannot find any cause for it. So probably would think this is a posterior ischemic optic neuropathy. The disc is not pale, but the vision is down and color vision is down. No, I mean, ERG was normal. They were asking about VEP. We didn't do VEP at that time. Yeah. Time for another one? So this is another patient. This is just to highlight our technical problems with dealing with patients. So this is a 72-year-old patient, Vietnamese gentleman, insulin-dependent diabetic, very poor control, anemic, HbA1c 10.4%, awaiting dialysis, bad feet, bilaterally pseudophakic, and he has had DMO and PDR. So he is a patient with all diabetic complications. So we gave him 8 Lucentis injection, partial improvement, and then he was put on Illuvin, which is the long-acting steroid. So this is post ranibizumab before Illuvin. You can see this. Illuvin is our agent which we believe will cause resolution of any type of edema, but this remained 3 months later, 5 months later, 7 months, 17 months. No response despite adding Anti Veg F to that. So this is a patient who has not responded at all to Anti Veg F or steroids. So partial responder to ranibizumab, no response to Illuvin, non-responder to Eylea. What do we do next? PRP done. Anyway, we have to just continue on adding anti-VEGF for him. We have free choice of anti-VEGF agents. Because of that, patient does not need to pay. We continued on it, but he had no response. Then we must also believe that there are several other pathways involved in diabetic macular edema. This slide just shows us that we do not know this disease very well. Of course, with anti-VEGF and steroid, we can reduce half of these, but it may be the other half that's playing up, and we do need new treatment for this. So what happened to this patient? So what happened to this patient is this patient then went on to have dialysis. Do you think the macular edema resolved with it? That's our teaching. This patient's macular edema didn't resolve. I don't know what sort of macular edema he had, but it definitely did not resolve. He also had amputation afterwards. He also had dialysis, as I said, and a year later he died. So he was sort of a terminal diabetic patient with all complications. And it looks like we have a few like this. At that point, it seems that nothing works for these patients. It's like we're just trying to treat something which is already lost its will to live. I think I'll stop here, right? In a bad note, though.
Yeah.
Lost.
Thank you. Yeah.
What's that?
Severe microvasculopathy.
Correct. His whole body, his feet gone, kidney gone, and eye gone. So
Yeah.
I should say he was very well in his brain, though. He was fine. He had no issues coming for his regular appointments. But in the last year, he did very badly. Correct. Yeah. Yeah.
Okay, thank
Thank
you very
you.
much. Thank you very much, everybody, and I hope you enjoyed the session. Thank you.